So good afternoon, everybody, and thank you for joining us this afternoon to hear about some of the work we've been doing at the Healthcare Safety Investigation Branch over the last 2 years, and especially focusing on some of the changes that we've made during the COVID pandemic. My name's Louise Page. I'm a consultant obstetrician part of the week, and part of the week work as the acting clinical director for the maternity programme at HSIB. And I'm going to be joined later in the presentation by one of my colleagues, Lou Pye, who's the head of family engagement at HSIB. So for those of you that maybe haven't heard of HSIB before, we were established in 2017 in England to look at doing independent safety investigations in NHS care. We are functionally separate to the NHS and independent from the NHS. Our purpose is to try and identify safety risks. We don't apportion blame or liability, and we very much are looking at system level changes rather than looking at individual healthcare professionals' care. Another part of our role is to aim to professionalise the patient safety investigator role, and some of that work is being done in collaboration with NHSI. Within the branch, we have a whole range of people from a whole variety of different backgrounds. Many will come from a healthcare background, others come from aviation and military, from human factors and other safety critical industries. We have worked with Cranfield University, which is a university world renowned in accident investigation, as part of our development. Every investigation is exposed to both clinical and non-clinical perspectives during the process of investigation, and as my colleague Lou will come on and talk about, the importance of family involvement within our work. We have a definite focus on learning, not to blame, but to try and minimise the chance of a similar episode happening and similar harm happening in the future. We are transparent and collaborative. We're not a regulator, and that does hopefully set us apart from some of the other organisations in the patient safety field. So within the maternity investigation programme at HSIB, for those of you that may not be aware of our investigation criteria. So the maternity investigation programme started on a phased rollout throughout England in 2018, and we were live in every maternity unit in England by March 2019. And our criteria are there on the screen. So we investigate babies that meet the RCOG Each Baby Counts criteria, and also maternal deaths that happen during pregnancy or within 42 days of the end of a pregnancy. So far to date, this slide shows our numbers of maternity investigations up to the end of June 2020. So you can see there that 1,358 investigations were commenced, and as of the end of June, 830 reports completed. The July figures show that we're now at just short of 1,000 completed investigations, with 977 reports completed by the end of July. In 2020, our focus is really on trying to consolidate and share the learning from those investigations. As I previously mentioned, we're working with all 130 trusts in England, along with the 10 ambulance services that work throughout England. We published in March 2020 a summary of our 8 key themes, and 2 of those key themes we've also published a more detailed national learning report, which I'll come on and mention shortly. We've also been working to use some of the intelligence gained through the maternity investigations into the national investigation programme at HSIB, and one of those reports will be published in the coming months, and that's looking at delays to intrapartum interventions once fetal compromise is suspected. Another national investigation report is underway looking at the suitability of equipment, technology and tools used for fetal monitoring. So moving to the national learning reports that have been recently published, our first main thematic report looked at Group B Streptococcus infection. This was based on the first 296 completed reports, where we identified there were 39 reports where GBS had been involved. Of that 39, 15 where it was felt that GBS contributed to the outcome. There were 6 neonatal deaths, 6 intrapartum stillbirths, and 3 severe brain injuries. And on the slide, I've just put the sort of 3 really, I suppose, headline take-home messages from the report. We identified that mothers who carry GBS are not always clear about when they should contact or attend the maternity units when they're in labour. And this is backed up by the fact that many women reported not receiving any information about GBS during the pregnancy. Sometimes there's a conflict between different guidelines, and one of the observations that we made was that women who are known to be colonised with GBS are not always invited in during early labour. And this may be because of the other guidelines within an organisation and other practice where women in the latent phase or in early labour are encouraged to stay out of the unit until such time that their labour is established. And this, for women who are colonised with GBS, may contribute to them being delayed in receiving the important intrapartum antibiotic prophylaxis. And final take-home message from the GBS report was around, there was definitely association that we saw with poor neonatal feeding as an important sign that a baby may be infected. So our second thematic report was around neonatal collapse alongside skin-to-skin contact. We identified 12 reports out of 335 completed reports at the time of this analysis. It's important to note, of course, that 82% of term babies in England have skin-to-skin at some point after birth, and the outcome of a sudden collapse in the neonatal period is extremely rare. However, it can have devastating consequences. We noted that in 6 of the 12 cases, positioning of the baby was an important contributory factor as to the collapse of the baby. So our learning point suggests that a baby who's well can safely be lain skin to skin with a mother or another parent, but they do require close observation in those minutes after birth, and that care needs to be taken to ensure that the baby's airway is clear and that it doesn't become obstructed. Another observation that we found was that parents may have raised concern about the well-being of baby, and that healthcare professionals may be engaged in many other tasks at this time. And it's important that healthcare professionals listen and respond to concerns raised by a parent at this time. And so thinking about some of the responses within the branch to COVID-19 pandemic. So it was identified that the adult national early warning score might not pick up on deterioration in COVID-19 inpatients. And this was recognised, and work was done along with the Royal College of Physicians to share the observation that any increase in oxygen requirements should trigger an escalation call, as this may not necessarily increase the NEWS2 score. We also made some changes to our maternity investigation criteria during the COVID-19 pandemic. We asked trusts to continue reporting all mothers and babies that met our standard criteria to us during this time. We made the decision not to routinely investigate the babies that had been referred, where they'd been referred after a possible brain injury, but following cooling, the baby was well, and most commonly this would mean that a baby would have had an MRI that showed no hypoxic or neurological damage, and the baby had gone home well with no ongoing concerns about their neurology. We then, once we'd established that a baby was well, we would liaise with both the trust and the family, and would choose to continue to investigate if either there were specific concerns raised by the trust or the family. So I'm now going to hand over to my colleague Lou Pye, who's going to talk about some of the work we've been doing with families during the HSIB maternity investigations.
Okay, good afternoon, everybody, and thank you, Louise. What I'd like to do is just to highlight some of the ways that we work with families, and the point that Louise just mentioned about considering families' concerns is a good example of how we are trying to make sure that patients and families are central to our investigations. So a few numbers, first of all. At the moment, within our maternity programme, we are working with 88% of the families that we would like to work with within our engagement. 12% of families have declined to work with us, and that is, of course, a family's right to do so. From that 12%, 5% of the families we weren't able to speak to at all, because we need to get consent from the family with the hospital that has referred the family situation to us before we're allowed to make contact with them initially. After we then make contact with the family, 7% of those families have chosen not to work with our investigations. There are varied reasons, the most common reason of which is the family feel that their baby is doing well, they have no concerns over the care, they are very happy with the care they received, and they don't feel that they would like to be involved or have time to be involved in an investigation. The other figure on the screen you see there is the engagement rate of our national investigations, which is another part of the work that HSIB conducts. So within our work with families and patients, we're very keen to make sure that we review and evaluate how we are working, what's effective and what needs improvement. So alongside the feedback we get from families, which I'll come on to, we also get feedback from trusts, staff at the trusts, and also staff within our own organisation to see where we can improve and where we can learn about our process. So what do we mean by family engagement? Well, first of all, we looked at what our principles are for making sure that we work with families. So initially, we want to make sure that the engagement work is personalised to that particular family, and indeed to individuals within one family. We define what we mean by family. It is family in the widest context of the word. So individualising our response, giving people informed choices is really important to allow them to work alongside our investigation. We need to make sure that our work with families is accessible and inclusive. So, for example, not every family that we would like to work with has English as their first language or their ability to speak or read English. So we need to make sure that our literature, our ways of working with families is accessible to those families as well. So as an example, we currently have 22 languages of literature for families that we have translated and is available. We've done completed audio versions of our reports to make sure that families that have some sort of barrier to communication is able to be included. We want to make sure that our engagement with families is open and transparent. We're honest about what we can achieve and what we can't achieve, and we manage expectations from the first time we contact families about what our investigations are meant to do, to make sure that we're not actually letting people down with what their expectations are of our investigation, and we can refer them on to other organisations if needs be. Clearly, we need to make sure that our investigations are respectful to the individual, the family, and the circumstances of the investigation. And we need to make sure that our investigations are timely, both in our response to the family after an incident's been referred, how we work with that family up until and including the report, but also to make sure that we're very aware that because we're working with families so soon after an event, that brings with it extra considerations. Families may be distressed, families may be grieving. We've defined what we mean by family engagement, which is the prompt, effective liaison between a family, and that is in the widest sense, as I mentioned, and the investigation, to make sure that the family is integral to the investigation. The family needs to be treated professionally, respectfully, and according to their individual needs. So what are the considerations and challenges that we've had in general, and also specifically in the latest period as a result of COVID-19? The barriers to communication I've mentioned already, and it's really important that we work to remove any barriers that are possible with families that we come into contact with. That may be language, it may be literacy, it may be understanding of any kind, but we need to make sure we remove those barriers wherever possible. We need to make sure we manage family expectations. Louise has already mentioned our changing criteria due to COVID, and it's really important that although families are being told that their case is being referred to us, it doesn't necessarily mean an investigation will be forthcoming, and we will explain that with the help of the trusts to families. We need to make sure that we give informed choices to families, and that we give a choice when there is one, and we make sure that we follow up on the choice that has been explained to us. We need to make sure that we support our investigators that are working with families, who will also in turn support the families. That means making sure our investigators are trained, they've got the right skills, they have the right training, they have the right support around them, they have the advice, and we support them in every way we can to make sure they're effective in their work with the families. And in turn, we need to make sure that we work with the families to signpost them when it's not our place to support them in the way that they need. And that's being most respectful of the fact that if a family, for example, is grieving, they may need specific bereavement support, or they may need certain specialised support that we're not in a position to give, but we can give the information to make sure that is put in place for them. So specifically to our challenges to try and deliver those types of considerations during this COVID period, we've been unable to visit people in person, which would always be our preference, subject to the families agreeing it. We've been unable to do that. We've had to return to remote interviewing, video interviewing with families, should they wish to. That's involved some barriers. Not everyone is familiar with the technology needed to do those types of interviews and meetings. So we need to support families to make sure that's effective as possible. We need to explain the change of criteria that we've mentioned already. We need to make sure that families realise why there is that change, but they also importantly know that they can express any concerns to us, which can also be considered when we review whether we will take the investigation forward. We need to explain, certainly initially, the delays to investigations that some of these changes have had. We need to make sure that we manage those expectations, and where there is delays, explain why there are delays and what we can do about them, if anything. So within our approach to families, what we will be doing, and will be published on the 17th of this month, is we've looked at a national learning report about how we work with families, and in the words of our report, how we give families a voice within the investigations. And within that, there are some take-home messages that I would urge you to consider to see whether they're relevant to your own situation. We feel through our processes and our reviews and evaluation of it, that it's really important that family engagement is defined, or family liaison is defined within an organisation, to make sure that there is a clear purpose as to what you're doing, why you are doing it, and the families understand that and contribute to it. The engagement must be meaningful. It's also important, we believe, that there is a structured approach with defined roles and responsibilities for those working with families, and they're supported and trained and developed to enable them to do that to the best of their abilities. It's important that we're consistent in our approach, however, allowing individualisation for particular families or family members to make sure that we give choice where it is possible. We need to make sure that we're flexible, that we remove any barriers to stopping a family wanting or being able to become involved in investigation if that's what they wish to do. We need to make sure we believe that there are support systems in place, not just for the families that we work with, but also for the investigators that work with them. And where it's something that we can't achieve ourselves, we signpost to the relevant individuals, organisations or charities. We believe that effective communication, ideally in person, if that's what a family wishes, allows for the best information to be shared, for families to be updated, and to make sure that they feel meaningfully involved in the investigation. And most importantly, we feel it's really important that families are given a voice within the investigations. So to finish, I think the most important thing perhaps is to allow some of the families' words to finish our presentation about their involvement within our investigations. And these are examples of some feedback received just in the last 4 weeks. Unfortunately, due to COVID-19, the final report was delayed from the original estimate due to many staff needing to re-enter the workforce, but we were kept informed about the delays and reasons for them. The investigator was very supportive and gave lots of personal help and advice, which we particularly appreciated during the COVID lockdown period. The HSIB investigation offered an invaluable service to us. It meant that a thorough and unbiased investigation was carried out into the circumstances surrounding the birth of my daughter, without us having to push for or ask for this to happen. Following the birth, we were in shock and traumatised, and knowing that this investigation was being done was reassuring and a weight off our minds. And finally, thank you for facilitating this investigation. What seemed like an impossible and horrible task for us at the start became an empowering journey and part of our recovery as a family. Thank you very much for your time today, and we hope that you've gained some insight into the work within the maternity programme at HSIB.